and somebody said something. Well, anyway, I'm going to talk. This is who I am. I don't have a video feed, so I thought I'd take a picture of me. But this is me. Actually, that's where I am right now in front of my one of my PACS workstations. So I'm going to be talking about thrombectomy, which has become standard of care. It's something we've been doing here at the Mass General since the early 90s, 1990s. And of course, it was very experimental, and very few places were doing it in the year. And we incorporated the use of imaging to select patients, and we learned a lot over the year. We published a lot over the year, and now it's become standard of care. Here in the United States and Europe, and ultimately it will be the standard of care throughout the world. We're talking about treating the most severe ischemic strokes there are. To illustrate how we do this, I'm going to start with a case of a patient who was flying from London to Boston on holiday, and halfway across the Atlantic Ocean, she became paralyzed on one side, and the husband told the attendant, "I think my wife is having a stroke." The pilot radioed into Boston Logan Airport. They got a hold of us at the ED. They called an ambulance, and when the plane landed 3.5 hours later, the patient was transported immediately to our hospital and was evaluated. When she got here, she indeed had a hemiparesis on her right, and she had an aphasia. So the first thing we do is for evaluation of this patient after the clinical examination is to try to figure out what's causing this sudden onset, this stroke syndrome. It could be a hemorrhage, it could be an ischemic stroke, it could be a brain tumor, it could be a wide variety, or it could be seizures. So it could be a wide variety of things. So we have to do imaging in order to understand what's going on. So this is the patient. The first thing we do is a non-contrast head CT, and this is the scan we took at that point in time. And you can see that there's information on the non-contrast CT. First of all, this arrow is pointing to a hyperdensity, a linear hyperdensity in the region of the left middle cerebral artery, which we don't see in the region of the right middle cerebral artery, suggesting that there's a clot, a thrombus or an embolus located in that location. There was also a very small area of hypodensity in the left subinsular region, which was not seen on the other side, suggesting a small bit of edema. So this is actually consistent with an embolus through the left MCA and would explain the patient's syndrome. Interesting, the rest of the brain looks perfectly normal, importantly. Now, according to our protocol here, once a patient has a stroke syndrome and the non-contrast CT does not show hemorrhage or a large completed infarct, they get infusions of TPA. But while we were infusing the TPA, and that's what happened to this patient, we did a CTA, a CT angiogram that's shown right here. And the CT angiogram confirmed what we suspected, that in fact there is a cutoff. There's an occlusion of the left middle cerebral artery proximally. But the CTA also gives us more information. You can see that the vessels, the arterial branches distal to the MCA, are very well seen, but there's an occlusion proximally. But they're very well seen. This tells us that, in fact, this patient has very good collateral circulations. The flow is coming retrograde all the way to the clot, and it's probably the reason why we don't have a large completed stroke. She has good collateral circulation. At this point in time, there was a question about whether or not we should do thrombectomy. And now TPA works on these types of strokes, but it only works around 20% of the time. Thrombectomy is something that's much more effective. So we decided to go to thrombectomy, but before we did that, we always get a diffusion scan to confirm that the core, the infarct core, is small. And this is the diffusion done just before she went on to thrombectomy, and you can see these multiple areas of diffusion, hyperintensity that are indicative of the core of the infarct, and it's actually quite small. This is less than 20 milliliters. So this is the perfect candidate to undergo recanalization, mechanical recanalization. We sent her to our angio suite here, and this is the angiogram done before and during the actual procedure. The panel on the right here, you can see the guiding catheter in the region of the proximal internal carotid artery. You can see the proximal, you can see the internal carotid artery, but we don't see much in the way of flow in the intracranial branches of the ICA, because there's a clot up there. Now, I'm not sure if you can see it very clearly, but there's actually a very fine microwire that's going through the clot. And over the microwire, a thrombectomy device, a stent retriever was placed. The stent was opened, allowing flow to go forward, and then the whole thing was retrieved, and the clot was pulled out of the patient's head. And this was the subsequent angiogram done about 5 minutes later. And you can see now that the internal carotid artery, both the ACA and the MCA and their branches are now entirely patent, and there's normal flow going to the brain. The patient, when she woke up from anesthesia, was entirely normal. And this is her CT scan 1 week later when she was normal. And she did, in fact, have a small infarct, but it was very small, and it's clinically silent. So this patient came from a very severe stroke. The probability of her surviving or having living a normal life was very low unless you treated her. In fact, she's now normal. So this is a major advance. This sort of therapy has a has the potential to have a major impact on the care of these patients. And this, there's been two things that have allowed us to make these advances. One is identifying the patients through imaging, the proper patients, and then use the development of these devices called thrombectomy devices that allow us to pull the clot from the arteries. Okay, so the topic of my talk here is going to be large vessel occlusions and how we treat them. And this is the large vessel occlusion the term I'm going to be using throughout the talk refers to occlusions of the proximal MCA, middle cerebral artery, or distal ICA. Okay, and this is what this therapy has been useful for. And there have been now multiple over the last 3 or 4 years. There have been over a dozen papers. These were the first 5 papers published in the New England Journal showing that in fact the thrombectomy approach is extremely powerful. In fact, the number needed to treat to have a good outcome with people with very severe stroke syndromes is 3. So this is much better than almost any other treatment out there for any kind of disease. So it's really quite phenomenal. Now, beyond that, subsequent to the initial studies, there have been a couple of studies where thrombectomy was studied in patients beyond the traditional 6-hour window. One was the Dawn trial shown here, and it was positive. And then the other one up to 16 hours was the Diffuse 3 trial. So now we know that the treatment window for these most severe strokes is up to 24 hours. So it's really quite remarkable. If you select the right people. You can't treat everybody up to 24 hours, but if you select them properly, you can treat them out to 24 hours, which is really important if the patient who has a stroke is far away from a comprehensive stroke center like ours, and you have to travel by whatever means you have. So the question is going to be, how do you identify them? Now, this is a map of the United States. This is where I live. And I'm up here in the top right corner here. These are major stroke centers throughout the United States. Bavia's over here on the other side of the country over here at UCSF, but these are the major stroke centers. And there's around 30 shown here. These are centers that are being funded by the National Institutes of Health to perform these types of procedures, but to also perform surgery. And it was through these centers that the advances were made. But as you can see, they're scattered throughout the country. There's 30 of these, and there's maybe another 100, maybe 120 additional centers that are not shown. But most of the centers are in large cities, okay? And most of the country does not have the cities, do not have ready access to advanced stroke imaging or advanced therapy such as thrombectomy. So what we have is a location mismatch between where the large vessel occlusion patients are and where we can actually treat them. So this is the big challenge, and that's the main focus of this talk, is how do we identify the patient that may be found, that may have their stroke up in Montana. This is Montana, way up here, but far, very far away from any center. how do we identify the patient that's likely to benefit from thrombectomy, and not just send everybody. If you sent everybody, it would not work. The system would collapse. So this is the topics I'm going to talk about. I've talked so far about thrombectomy, how it's now the standard of care. I will now talk about where I see our future going. And the future is identifying patients in locations that do not have ready access to thrombectomy and bringing them giving them proper care. So to do this, I'm going to first review basic physiology of large vessel occlusions and what determines outcomes. And I've already given the answer here. The most important factor is the size of the infarct. The actual volume of the infarct is the single most important determinant. I will then talk about a very special subset of patients. These are patients that have these large vessel occlusions, middle cerebral artery occlusions, for example, but they progress very slowly. And by this, I mean the core of the infarct grows very slowly. And because of that slow growth, because of this slow progression, they are optimal patients to select to transfer for treatment at a place that may be many hours away. And finally, I'll conclude with some thoughts on artificial intelligence, some of our work that we're doing here at the Mass General, and how we're implementing AI to help us in identifying patients. Okay, so let's start with physiology. So this is the classic LVO patient. This is an individual who had an embolus that settled and occluded the proximal right middle cerebral artery. Immediately after, or shortly after the embolus lodged in this location and caused occlusion, a part of the brain is injured irreversibly. This is the core of the infarct. But there's two other parts of the physiology here that are extremely important. The other one is called, the other part, which is shown in pink here, is the penumbra. So this is the part of the brain that's still alive. However, it's a part of the brain that the flow is reduced. It's reduced to the extent that the patient has symptoms, but the flow is not reduced sufficiently enough to kill the neurons and the brain cells in that location. So these are symptomatic areas. They're hypoperfused, but they're still viable. And the reason they're still viable is the presence of collaterals, and they're shown right here. And I showed you the collaterals on CTA on the index case that I showed you at the beginning of my talk. Well, with time, if you do nothing, the core will grow. It will definitely grow, okay? However, it doesn't grow at the same rate in every patient. And the reason is that everybody has a collateral flow that's variable. Everyone has a different collateral flow. Some people have excellent collateral flow and the growth is very slow. Other people, unfortunately, have poor collateral circulation, and there's growth, very rapid growth of the core, and there's usually very little time to help these patients. So the core growth rate, which is a critical factor, is a function of the collateral circulation, and it's highly variable. Another really interesting and important concept that you need to understand about this LVO system of the anterior circulation is that it's a closed circuit, okay? And because it's a closed circuit, because you have, the occlusion here, but you have collaterals, the core and the penumbra are not independent variables. If the core is small, the penumbra must be big. If the core is big, then the penumbra must be small, because they're linked by the collateral circulation. It's a closed system. So you really only need to determine one of the two to estimate the size of the others. Okay, now let's talk about imaging and how we use imaging to identify and estimate the size of these various physiological variables. We have a lot of tools. For occlusion, we have CTA and MRA. They're both quite effective. CTA is actually a little bit better, but they're both quite effective in identifying a large vessel occlusion. The core, we have several techniques. We have non-contrast CT, which is the traditional method, but it's usually insensitive in the earliest hours. Diffusion is the most powerful method, the most accurate method, the most precise method for estimating the core. We can also estimate the core using CT perfusion, and also probably equivalently to the CT perfusion, you can use the CTA information, including collateral information, to estimate the size of a core. For the penumbra, you can measure it directly with the perfusion MR or CT. However, the neurological examination also gives you a good sense of the area at risk. So there really is no need to directly measure the core, especially, I mean, the penumbra, especially since if you already measured the core, you can estimate the size of the penumbra. So you really don't need to image the penumbra. In terms of the core, I've already mentioned that the non-contrast CT is insensitive early on, so it's not very useful in most cases. And CT perfusion is not as good as diffusion, and we believe that CTA, information on CTA gives you equivalent information. So these are the techniques that we use here. We do CTA primarily to identify the occlusion. We use the CTA also to assess the collaterals and probability of a small core. And if we need to confirm the core size, we'll go on to diffusion before we would go on to therapy. Okay, so there are many variables that I've talked about: the site of the occlusion, the collateral circulation, the penumbra, so on and so forth. Which is the single most important variable? It turns out the data has now come back, and it's very clear that the infarct size is the key to patient outcome. This is a paper that brought together the data from multiple trials, 7 or 8 trials, over 1,000 patients, and it's called the Hermes collaboration. And they looked at the core after thrombectomy, and they looked at the factors before thrombectomy to see what and they also looked at the likelihood for good outcome 3 months after thrombectomy. So this is a complicated slide, but it's probably worthwhile looking at it. It's a 3-dimensional plot here. So at the baseline down here is the baseline measurement. This is the neurological deficit. This is called the NIH stroke scale. So this axis here goes from 5 to 30. 30 is a very severe symptoms. It's severe paralysis, inability to talk, it's just very severe symptoms. At 5, the symptoms are very, very mild. On the perpendicular to this, on this scale here, is the size of the infarct. These are all patients that were treated. They were all underwent thrombectomy. This is the size of the infarct volume. You see how it goes from 0 out to 150. Finally, the vertical axis is the likelihood of a patient having a good outcome. And this is a scale, the modified Rankin scale. And if you have 0, 1, or 2, you can live independently. That's considered a really good outcome. So you really want to be 0, 1, and 2. So this is the probability of a good outcome versus symptoms when you first arrive and size of the core. And you can see that this plane here takes a big dive very quickly after 50 milliliters, okay? If your core is under 50 milliliters, the probability of a good outcome is very high despite how bad the symptoms are, okay? So that is a key variable. It doesn't matter what your symptoms are. If it's under 50 milliliters, you're going to do very, very well. So this is the key variable. Favorable outcomes. If your infarct is less than 50 milliliters, you're going to have a good outcome. You're going to live independently if the thrombectomy is successful, and thrombectomies are successful 90% of the time. So this is a good variable. So now I want to focus on what I mentioned before as the slow progressors. These are patients that have slow infarct growth, And because of the slow growth of the core, they may be treatable up to 24 hours after the onset of the stroke. Okay? And so we wanted to figure out how many patients, because now we know that the threshold is really is a good threshold to use is 50 milliliters. We wanted to know, what we wanted to figure out is which patients would have a small core after 24 hours. And in this country, we figured that we could get basically almost anybody in this country to a thrombectomy center within 24 hours. So that's why we selected this 24-hour goal, slow progressors. Now, we started noticing, many years ago, that some people had very slow growth. And we had a hard time publishing this data because nobody believed us. It finally got published in BMC Neurology back in 2010. But what we were showing was that, in fact, some patients have very, very slow growth. For example, in this patient right here. So this patient had, he wasn't treated. He had multiple scans after he arrived. I'm not sure why he wasn't treated, but he wasn't treated. He had a left middle cerebral artery occlusion. And the diffusion, you can see when he arrived, it was 5 hours after stroke onset. It's relatively small. It's well under 50 milliliters. This is the perfusion abnormality, the penumbra, if you will, and it's very large. And we scanned him again at 13 hours, at 1 day, and 2 days after stroke onset. The occlusion persisted throughout this time. You can see that you still have a big perfusion deficit, but the core, it grew, but it grew very small. In fact, even up to 2 days, the core was still less than 50 milliliters, and we would predict that if you treat them, this patient would live independently. So this is the patient, the type of patient that we would want to identify. So after that paper was published, we did a series. We studied a series of patients where we scanned them multiple times over 2 days. These are all patients who had occlusions, and none of them were treated with thrombectomy. So this is a while ago, before thrombectomy became a standard of care. We broke up the patients into those that arrived with core size, or when they were first imaged, they had core volumes of less than 50 milliliters, between 50 and 100 milliliters, or an initial diffusion volume of greater than 100 milliliters. Now, looking at this large group over here, the large core group, you can see that these patients mostly have infarct growths that are very fast. But if you look at this group over here on the left, the patients that arrived and had infarct cores of 50 milliliters or less, those lines are really flat. In fact, there's something like 18 patients here, okay? And all but 3 patients had cores of less than 50 milliliters 24 hours after stroke onset, okay? These guys grow, but they grow very, very slowly. And it turns out the majority of these patients, of all the patients, had this particular physiological biomarker of a small core. That means that they were going to grow slowly, and that suggests that they were going to be likely to be treatable. So because we had a time series, we were able to try to figure out which were the factors that would predict who would have a core of less than 50 milliliters at 24 hours. And we looked at a bunch of clinical factors as well as imaging factors. And it turns out that the best predictor of a good outcome, or of a small core at 24 hours, is the initial infarct growth rate and the core volume when they first came in. If you met one of these criteria, the probability of having a small core at 24 hours is over 90%. So how many of these slow progressors are there? Well, there's actually a significant amount of published data out there. How many people meet the criteria of less than 50 milliliters when they first arrive? The published data, or slow infarct growth rates, there's 5 publications that measured initial growth infarct rates in patients with large vessel occlusions. These are the publications by these various people here. This is ours. Wheeler is out at Stanford, multi-center trial. This is Pittsburgh, also multi-center trial. No, yeah, this is Cincinnati, and this is Paris. So these are studies from all over the world. And you can see what the median growth rate for each of these trials. Now, I said for growth rate, all we need is less than 5.4 milliliters. And if you look at the median, all of them but one study is less than 5.4 millimeters at the middle. So over 50% of most people that show up with a large vessel occlusion have a slow infarct growth rate and are treatable for 24 hours later. So how many of those? It appears from the published study about 50% of all LVO patients are slow progressors, and that's a huge number. To give you an example, in this country, there's about 200,000 large vessel occlusion patients every year. 100,000 of those patients are treatable 24 hours after stroke onset. That's a huge, right now we're only treating maybe 10,000 of them. So it's a large number of patients that we could be treating if we could find them. Here's some source data from some of these papers. This is from our hospital. There's some 186 patients. This is the size of the diffusion lesion volume when patients arrived, and that's the horizontal axis. I mean, the vertical axis is the core volume. The vertical axis, I mean, the horizontal axis is the time after stroke onset, and you can see that it goes from 0 to 24 hours. Each circle represents one patient. So this is, for example, a patient here who arrived around, well, this one here arrived around 12 hours after stroke, or was imaged 12 hours after stroke onset, and he had a core volume of around 225. So this patient would clearly not be eligible for treatment anywhere. So that's that patient. But look at all the other patients. This blue line that I've drawn here in horizontal fashion is the 50 milliliter line. And you can see that the majority of all the patients are under this patient. These are the slow progressors, okay? And there's lots of them. In fact, the majority of patients are slow progressors. 62% of these patients are slow progressors. This is a totally different trial. We had nothing to do with these people, but they published the data. Each dot also represents a patient. The fusion volume is here. Time after stroke onset, this goes out to 12 hours, but you can see, once again, the majority of patients are slow progressors. This is a third study published by Olivo in Paris. And again, this is a logarithmic scale, so it's kind of funny looking, but it's still, it goes out size versus volume, and you can see the majority of patients are slow progressors. So this is pretty hard data. The question is, how do we identify the patients out in places that may not have the proper imaging, or at least not the most advanced imaging, and may not have proper analysis tools, and may not have properly trained neuroradiologists? How do we deal with that problem? And that problem is not just in this country, but actually all over the world. How do we find the patients that are treatable, these major stroke patients that are treatable? How do we find them so we can transfer them to proper treatment? How do we find the slow progressors? And this is what I call the future here. And I see the future. I think it's very clear that we'll be able to accomplish this through the proper implementation of artificial intelligence, which is what I'm going to conclude my talk on this topic, because it's an area that's moving really, really fast. I'm talking specifically about deep learning using artificial neural networks. These neural networks are based on how our own brain works. And all of you went to medical school. If you recall your basic neurophysiology, the fundamental computing unit in the brain is the cortical column. It's made up of maybe 100 million neurons, and there's numerous, many connections between them. But the basic computational activities of the entire brain is carried out within these cortical columns. And so we bring in information through our senses. For example, someone who's learning how to interpret head CTs, the information comes in, neurobiology takes over within the brain, and then that results in information from learning how to interpret head CTs by using our eyes and by learning and trial and error till, as you guys do there, you men and women that are learning neuroradiology, you keep looking at images until you learn how to identify the difference between a normal and an abnormal, and you convert images into information. In this case, is there a bleed or is there no bleed? Well, in recent years, there have been huge increase in the computational power of our computers. It's just phenomenal. You have these what they call graphical processing units that are basically supercomputers on a chip. There's also been development of very, very sophisticated computer software that has developed these what they call artificial neural networks that are similar in structure to the cortical columns. And now we can bring in data gathering systems that are artificial, and you can bring in digital information, CT scans of strokes and no strokes, and you can process and you can have these units learn how to distinguish between a hemorrhage or no hemorrhage, and you come up with the similar information as a human being. So that's how it's converging. These artificial neural networks, they work through layered nodes, as they call them. And what you do is you have to give them a lot of data and you have to label the data. But when you do that, it's an iterative process. And as data goes in, the nodes put different weights, and that increases the accuracy of the classification to a certain level, in this case over 90%, which is usually the target. So that's how artificial neural networks work. So moving forward, I see that this is how we're going to organize our healthcare system for the treatment of stroke. Right now, we're very fortunate in the United States in that most places, everywhere, Montana, everywhere else, there's CT scanners everywhere. They don't have people that can do thrombectomy, but CT scanners are available basically everywhere. Now, the CT tech may not know exactly what kind of scan to do on a patient with acute stroke. They may only see one of these people a month, and there may not be a radiologist available to interpret them. But that intelligence can be embedded from the cloud to these patients. And if you embed that intelligence, then you can get the proper imaging. And as I will show you, can also interpret the images all at the same time while you're communicating with ambulances and the Comprehensive Stroke Center, where you can have effective thrombectomy. These are some slides that have been loaned to me by a group in General Electric that we're working with to develop a series of stroke algorithms to help with this project. So this is an overview of the process. Someone comes in with a symptom, and what we do is we scan them with CT scan, and what we'd want to do is create algorithms to either detect a hemorrhage or a large ischemic completed stroke. If neither of those are there, then they would go on to get a CT angiogram to assess whether there's a large vessel occlusion, and also to assess the algorithms. Finally, if the patient is transported, the hospital that receives them would have an MR. They'd be prepared for it to see the size of the core, which is the most important algorithm, and we would use at that point the most sensitive and precise method, diffusion, and that would be done. So that would be an algorithm there. And GE, we're creating the algorithms here at the Mass General, but GE is going to incorporate it into a communication and collaboration system where all of the providers and all the systems within this network will be linked up, and everybody knows what's going on simultaneously. So that's the plan. So these are the algorithms we've been working on over the last year and a half or so, and they're pretty far developed. One's an algorithm to detect hemorrhage in non-contrast CTs. Another one to estimate the core on non-contrast CT. A third one is to identify the occlusion based on the CTA data, and also a collateral algorithm to assess the quality of the collaterals. And finally, we've already developed a diffusion weighted imaging algorithm that identifies the diffusion lesion and quantifies it. So these are the various algorithms that we've been developing. I don't have time to go over all of them, but I'd like to talk about a couple of them. This one's really important. Anybody who comes into the emergency room and gets a CT scan, we always have to exclude the presence of a hemorrhage. So just having this algorithm alone would be a huge boost to CT scanning locations everywhere in the world. So hemorrhage detector. We've already developed it. We've published this data in Nature Biomedical Engineering. And what it does is it tells you, it classifies, tells you where there is a hemorrhage. It tells you where a hemorrhage is, in this case, subarachnoid hemorrhage, and then gives you a heat map where it shows you where it thinks this abnormality is. And you can see, this is an easy case, but you can see that the algorithm was quite was spot on. But it's good in even more subtle cases. For example, this is a patient who came in with some mild trauma, and there's a subtle subarachnoid hemorrhage on this patient. I'm sure you all can see it, right? You can all see the subarachnoid hemorrhage. Well, the computer thought that there was a subarachnoid hemorrhage in that location. And if you look closely, there it is. In fact, this patient did have a small subarachnoid hemorrhage. This is a test of comparing the algorithm with 5 different individuals, residents, fellows, and staff. And you can see that all the staff and all the neuroradiologists fell on this curve. So this tells us that, in fact, this algorithm is performing as good as neuroradiologists in detecting intracranial hemorrhage on patients on CT. So that's the hemorrhage detector. I want to say a few words about the acute ischemia algorithm that we've developed. So identifying acute infarct on non-contrast CT. I've already told you that it's not so easy to detect an acute infarct, especially in the first few hours, 3-4 hours out. It's very hard to identify an acute infarct. Usually, if you see something, you'll see some blurring of the gray-white junction. You might see some hypodensity, but it's pretty hard. So we wanted to develop an algorithm to help us with that. So these are 4 different patients. They have something in common. What they have in common is they all have ischemic strokes. However, some are well seen and some are not so well seen. So the one on the left, it's very clear. You can see it's a left PCA distribution, hypodensity, very well seen infarct on the left. The second one there is, you can see it, it's subtle, but there's a subtle hypodensity in the left parietal lobe. This one here is very hard to see, but it's there, and you don't see it at all on this scan on the far right. So they all have ischemic strokes, but the visibility is quite variable to the naked eye, basically. However, in all 4 of these patients, we did diffusion right afterwards. And this is the diffusion scan from those patients. These were all done within half an hour after the ischemic stroke, the non-contrast CT was performed. And you can see now the infarct is very easily delineated on diffusion. So in this hospital, we've been very fortunate. We have an MRI in the emergency room. So we've been collecting data on ischemic stroke, non-contrast CT data, followed by diffusion data in thousands of patients. So we have a unique data set, and we figured that we could use this data set to teach our algorithm how to detect strokes on non-contrast CTs, teach them. So we had these data sets of non-contrast CTs and a DWI from the same patient. We co-registered the data. We segmented the diffusion, segmented the size of the core based on the DWI, and then we used that to teach the algorithm. And these are some results. And this is the work on this patient here has an infarct. This is the prediction of where the infarct is based on the algorithm. So the algorithm in green here, the algorithm states or presents in green the size of the infarct. This is where the infarct actually was based on the DWI obtained on the same patient. And you can see that it's very, very close match there. Here's another one with a smaller infarct on green. This is the prediction by the algorithm in this patient with the right MCA occlusion. And this is the actual infarct on the DWI. Again, not perfect, but clinically useful. This is useful information. This is useful information. The one on the top is a left middle cerebral artery occlusion. The one on the bottom is a right middle cerebral artery occlusion. The top person we would probably not treat because it's a large infarct already. We wouldn't help them. We might cause a hemorrhage. So it's likely that we would not treat this patient. The patient on the bottom, we would definitely treat. So having this information without having to go to diffusion would be very, very powerful. Also, the one on the bottom, this one is clearly less than 50 milliliters. So if this patient was scanned far away from Boston, and we found this information, we would strongly recommend that this patient get transferred, even though it might take several hours, even 10 hours or 12 hours before they were treated, because it's small and it's likely this person is likely to be a slow progressor. Anyway, we tested this study on 476 patients. 279 were negative and 197 positives, and the stroke accuracy was around 77%, which is better than any stroke accuracy in humans that we've ever seen done. We did a study like this in a non-contrast CT. We optimized it using various ways, and we got about 60% accuracy in the first few hours after stroke onset. So this algorithm is now performing better than humans. So that's where we are. We're about to move forward to complete and actually implement these algorithms in our hospital, and then hand over the algorithms to GE so they can spread it over around the world. And just to conclude here, this is what I see the future. I've already spoken about it. We would have everyone will be hooked up on the network through the cloud, and with intelligence embedded in every in every node in the system to help us identify the patients with the most severe ischemic strokes, identify them, identify the ones that can tolerate long distance travel, but still urgent travel and emergent travel to a place that is capable of doing thrombectomy. And that concludes my talk this morning. I've discussed thrombectomy, how it's become now standard of care. It went over 20 years from a very experimental therapy to one that's very effective if you select patients properly. I've talked about large vessel occlusion physiology and their infarcts, and that the key variable is the infarct size. I then talked about how there's a large group, probably half of all large vessel occlusion patients, that are slow progressors, and that those are the best people that we can transfer long distances. And finally, I've shown you how we might be able to identify these patients using artificial intelligence, which is what we're developing now and we will continue to develop. Thank you very much for your attention.
Thanks, Gil. This was excellent, very inspiring.